this patient came in, oops, trying to make it bigger. What just happened? Came in, they have a history of retroperitoneal fibrosis. And this was the lesion here. Basically, we can see that there's expansion of the psoas and iliacus muscle all the way down into the pelvis with like kind of dystrophic calcifications. So initially, I was thinking with all these big chunky calcifications and this expansion, that this was like a acute on chronic hematoma. And like there was all this, you know, just kind of like calcified hematoma from the old part, and maybe there's like recurrent bleeding and things like that.
But it looks like there's periosteal reaction in the left iliac bone, like a mass arising from the iliac, like a sarcoma.
Yeah, that was another possibility. And you can see that probably there's some enhancement in here. So they biopsied it, we biopsied it, and it came back gastric cancer.
Oh.
And if you look back at the stomach, they actually have been having a lot of vomiting. And they actually had an ulcer over here in the antrum. I can't see the ulcer part well, but it does look like it's thickened and maybe there's gastric outlet obstruction. And so this was a gastric cancer that had metastasized, intramuscular metastasis. So I was reading a paper about it. So intramuscular metastases are rare. It's usually from lung, GI tract, or breast. It's a little bit unusual since actually muscle is like 50% of our body mass and pretty vascular, but the muscle has some kind of like protective cytokine. So usually it can protect itself from getting metastatic disease usually. So intramuscular mets are rare, but you can get it from like GI and lung. And when you, I found like there was like a case study where it showed all these different ones, and they said about 30% of them will have calcification in them. So anyway, look like, yeah, the intramuscular mets. So if you see this, you think about a sarcoma, don't have satisfaction of search, kind of go elsewhere and be like, okay, is this a met? And like, do I see the primary even on this exam? And I've over here.
Yep, right there.
Yeah. So probably bilateral. Yeah. And then actually I have a companion case. So this lady had breast cancer and had a similar kind of like calcification along the iliacus, like all the way to the insertion. I don't know, usually I think that's like some old injury or hematoma or some kind of like myositis ossificans or whatever. And this is actually the first presentation they had. This is a later scan, but then they developed these calcified lesions in the back. So it's getting more suspicious, right? Like, but anyway, we biopsied this, and this lady also had gastric cancer, and you can actually see the gastric cancer very well here. So this is like diffuse linitis plastica. All the rugae are gone. Even it's extending into the esophagus. These have a very poor prognosis. And in this case, this was actually like, there was a lobular component of this, which you can get lobular breast cancer metastasizing to the stomach. So for a second, they thought maybe it was breast cancer, but then they tested it for ER or PR and it was negative. So they think that it is just an infiltrative gastric cancer with intramuscular mets.